Goa madam. Now I welcome Dr. Suma Ganesh for her presentation on how to get straight eyes in paralytic strabismus surgery.
That was an excellent presentation, Dr. Sujata, and as all of you presented so well. I will just talk about paralytic strabismus surgery. I think most of it has been covered, so I will not go to. Basically, when we have paralytic strabismus, we need to, I don't know, there are not many students here, but it is for basically to rule out whether it's congenital or acquired. So if it is normally when it's acquired, there'll be diplopia, and so you also need to note the abdominal head posture. So ductions and versions are very important. So we should do ductions and versions to know how much is the limitation. So because that will depend on our surgery. Our surgery also depends on how much there is limitation. Whether it is a -3 or a -5. So how much do we want to do, or what procedure we want to do? Do we want to do a recess resect or a transposition? So this is very important. And whenever you're doing a vertical, when you want to check the verticals side, then you need to check both the eyes so you can compare. So you can compare both the eyes and you can know which is an overaction, which is an underaction. So this is basically what we'll do in vertical squints. Now all of us, whenever there's an hypertropia in the primary position, we need to do the Parkes 3-step test. Okay, we cannot say that we cannot do this test. So so now here's a patient with a left hypertropia, and which is increasing on right gaze, and I'm not going to the details of this because there's lack of time, and it is increasing on left tilt, so we know it is a left superior oblique palsy. So whenever there is a left superior oblique palsy, the patient will present with a tilt to the opposite side. So when you're OPD, when you're seeing, you can make out the child is presenting with a tilt to the opposite side, and so you get a clue that okay, maybe this child has, maybe there is superior oblique palsy. And when you have a child which is presenting to your clinic and you have a hypertropia and your tilt is to the same side, then you know it may be the other side, inferior oblique palsy. So now this is how you can detect, even by not, because very small children, they may not be all so much cooperative for you to measure in all gazes, but these can give you clues that this could be a superior oblique palsy or this could be an inferior oblique palsy. But remember, these tests have to be done. We can't just do in the primary position and say, oh, this is hypertropia, and then leave it like that. Okay, so we need to do, because we also need to differentiate whether it is a hypertropia, or Dr. Sujata ma'am presented, whether it is a DVD. So we know that when there is a DVD, what happens? The other eye does not come up. So whenever there is a hypertropia, this eye is coming down, then the other eye is coming up. So this is how you differentiate between a DVD and a hypertropia. So these are very important so that you do not cause any surgical flaws. And also we need to measure in all gazes to find out whether there's an alternating hypertropia. That's why we need to measure in both the gazes, because we might miss a bilateral superior oblique palsy. So in bilateral superior oblique palsy, you might just do one inferior oblique recession, and then after 1 month you'll find the other eye is going up. So these are the tips, like you don't want to make faults like this, so you need to measure. So measure 2-3 times if you're not sure, and measure in all gazes. So when you find that there's an increasing ezo in down gaze, like a V pattern, V esotropia, and there's an alternating hypertropia, then you suspect a bilateral superior oblique palsy. So then forced traction test is very important. I think this is one of the most important tests which we need to do, because of this child, both are having elevation deficiency. The elevation in, so duction, we find that there is elevation deficiency. But now we find that, now I want to differentiate what? So when this eye is not going up, maybe it could be an inferior oblique underaction, or what else could it be? It could be a tight muscle, like which Dr. Shubhangi ma'am will talk about. So it could be there are browns. So how will I differentiate it? By doing a forced duction test. So you have to do these forced duction tests in the OR to know, because sometimes you may not be able to really differentiate. Of course, in ioparesis, normally you will get a Parkes 3-step positive, and you have, when there's an IO underaction, you will get an A pattern, because the superior oblique is overacting the antagonist, so you will get an A pattern, whereas in Browns, clinically what you will get always a V pattern. So these are these clinical tips will always be there, but we need to do a forced duction test always in the operation theatre. So similar way, in a superior oblique palsy, we need to do forced traction test. We need to check the laxity of the tendon. So we want to know whether it's mildly lax or moderately lax. So here you can see that there's no limbus is not seen at all. So in this case, will a inferior oblique recession help? May not help. Maybe IOAT might help when you can plan an IOAT, but it is always better in these cases with such a lax tendon to do a superior oblique tuck. Okay. Now tuck is just like plication. Now most of us are doing plication. So, but only in tuck we are always afraid of creating a Browns. So we need to do it, like we need to check before, like that we're not created a Browns. So now this is a 6 nerve palsy. We can see that there's a -5 abduction deficit and there is concomitant strabismus. Okay, you can see that. Now I personally am not a big fan of modified Nishidas. I'm sorry, but I'm not a big fan. I have not got good results. They're always residual and patients are not happy. And so maybe it works in very good hands. Maybe, I don't know, I've not got good results. So I myself do, so there's a traumatic 6 nerve palsy. So this is why you'll do a Hess chart. And then as time tested, like how we say the standard procedure, I still do a half split VRT because I find that this works and it has always worked. So, so we can, but of course I'm not saying that modified Nishad, you have to know it because there might be instances where you have a patient who might have an anterior segment ischemia risk factors, so you need to know the procedures. Because you can't say, I have not done Nishida, so I will not do Nishida, and that patient has iris angiography showing that this patient is prone towards, because an elderly patient with a diabetic, so you will have to know these procedures. But a young patient like this, so in this I've done a half split, so I will transpose it, and whenever you are transposing any muscle, we need to recess it as far as possible, otherwise you cannot transpose it properly. Your muscle does not come only to your transposition area. So you need to transpose it, so the upper half, so I've transposed the temporal halves of superior rectus and inferior rectus to the lateral rectus. So now when you are transposing, you do not get the full effect. You want that the abduction effect to be much more. So what you do, you will add on a posterior fixation suture. So at 8 millimeter beyond, what you will put like a non-absorbable posterior fixation suture, a Foster's method which is called as, so that it improves your abduction more. Because even after this, you may not get your full. So here you have a -2. Patient is still not happy because he feels that he's still seeing double in this case. So, but this is what we can give. Maybe modified Nishidas, if they're given more, then I would naturally shift it to modified Nishidas. But what I find is that this at least improves it from -5 to -2 and improves your field of. Now this again another patient with a third nerve. So there was a marked head tilt with limitation in adduction, elevation and depression. That's the biggest problem with third nerve. Like you have all the muscles gone and then you have a torsion. So in this case, you have a left hypotropia with a exotropia. So exotropia of around 50 prisms with a hypotropia. So best in this case is when you have like this a condition, is best to do is a large recess resect for the exotropias, and also I did a superior oblique tenectomy, because otherwise you will never get that head straight, you will never get that torsion improved, or you will not get. So I'm sure madam would have preferred a chicken suture. Like you could do a chicken suture also, because tenectomy, Dr. Pradeep Sharma says, Suma, don't do tenectomies because it is scary, because you may create a palsy. So, this was so large that I was sure that it is not going to create any much problem. The hypotropia was so large. So better is to do a chicken suture because you can tailor it. Okay, because tenectomy you do not know, even if you do, so you may not know what the effect will come. So similarly, you can do, the same thing which I have done, recess resect. So now this is a total congenital third nerve palsy. And in this case, best is to do, I feel the best procedure is a lateral periosteal fixation. Because if you do not remove that action of the lateral rectus, it always drifts and the patient is never happy. So it is best, so I'll just show a small video of this. So you can take the help of for lateral rectus, you don't need the help much of a plastic surgeon. But for medial rectus, I do take the help of the plastic surgeon, because in that you are dealing also with the sac. So here you are disinserting the lateral rectus. Sometimes I feel, why don't we just disinsert it and create a lateral rectus palsy? But it will go and attach somewhere. That's the reason. So it may go and attach anywhere. So that's why you need to fix it to the periosteum. So you open up this is not so difficult, the periosteum, to open up, because there's no structures which are really, which will hamper. But in the medial, I'm always scared that you have the sac there. So, and then just with a non-absorbable suture, you just anchor it to the periosteum. Wherever your lateral rectus is the biggest culprit. But in these cases, there should not be any hypotropia. So if there's hypotropia, this doesn't work so much. So she nicely presented on double elevator palsy, same thing. This also had same 20 exo with RHOT. So we could do, she said we could do a Nishidas technique, or we could do a NAPS procedure. So in this, what I did was just one muscle because exo of around 20. So did a medial rectus transposition with an inferior rectus resection. So we need, and then a litosis surgery. So we need, so the tips are that first and foremost, we need all the tests to be done, like the Parkes 3-step test, the FDT, and we need to do ductions and versions properly. And then we need to assess in all gazes, and that's how we can get a perfectly good result. Thank you.
Thank you, ma'am. One important point, very nice presentation, especially about primary and secondary deviation. I mean, for all paralytic strabismus, it's always important to know the refractive status of the patient, because sometimes the paretic eye will be the better seeing eye. So apparently you will get something which is actually a secondary deviation, especially for fourth nerve or even sixth nerve palsy. So that is one point which you need to remember, and you need to correct the secondary deviation in almost all these cases.
Yeah.
Thank you, ma'am.